spine and bone health. We've got Doctors Paul Anderson and John Dymar today, who are the co-chairs of the Spine Health Foundation's Task Force on Spine and Bone Health, a group that we pulled together in Q4 last year to get some guidance on how to best educate both healthcare professionals and consumers on the connection between spine and bone health. You can see the members of our task force to the right. I'm really excited to be being able to kick off this webinar series today for continuing medical education.
Well, thank you, David. And again, welcome everybody who's participating. We're going to go over how do we actually diagnose osteoporosis for the spine surgeon. This is not as straightforward as one may think. Here are my financial disclosures, and they should have really nothing to do with this presentation. The objectives are to look at the limitations of the DEXA-based diagnostic criteria and redefine a concept called clinical osteoporosis, which also includes risk stratification, which provides a pathway to develop treatment recommendations, as well as surgical risk for our patients undergoing spine surgery. So what is osteoporosis? So osteoporosis is defined by an NIH consensus definition, is decreased bone density, bone mass, or the quality and structure of bone that leads to a decrease in bone strength that can increase the risk of fracture. And I think the emphasis here we need to think about is increase the risk of fracture. I think it's a great definition. However, it doesn't really provide any clinically useful metric for us to diagnose osteoporosis. So another way of looking at fracture risk is the inverse is bone strength. And bone strength is really what we want. We want more bone strength for the patients to prevent them from fracturing, but also to have better outcomes from spine surgery. And bone strength consists of three things. Bone density is only one component. Bone quality, which I will talk about in just a few minutes, and as well as bone geometry. And all of these three things change the structure of the bone and lead to bone strength. So the gold standard for bone density measurement is the DEXA scan, and this has been around for over 30 years. And I would say that the spine practitioners really need to be competent in interpreting this study. Just like all of the other studies we look at, CT and MRI, we read them ourselves. You need to begin to learn how to read and interpret bone density results. And remember that the results we're going to look for are really statistical results, which is a T-score, which is valid in postmenopausal women and men over the age of 50. And this is basically the number of standard deviations away from a reference standard the patient's bone mineral density is. The reference standard for the postmenopausal women and men over 50 is young, healthy Caucasian females. And that will derive a T-score. And that's most commonly what we're going to use. There is something called a Z-score, though, and this is for premenopausal women as well as men under the age of 50, and particularly adolescents and younger adults. And the Z-score is the reference group is age, gender, and race matched references. And the Z-scores are interpreted as greater than -0.2 is normal bone mass, and then less than or equal to -2 is less than expected bone mass, aka probable osteoporosis. Now, one thing about interpreting the bone density, we don't have time to go into this in great details, but really what you're looking for is the lowest T-score of the total hip, maybe called proximal femur, femoral neck, spine, and 1/3 radius. Keep in mind that our spine population has increased T-score somewhere between 1 and 1.5 standard deviations. Also that if you have greater than 15 degrees of scoliosis or kyphosis, you really can't interpret the DEXA of the lumbar spine. It's not valid. In these cases, hopefully the technologist would have done a radius scan, and you could substitute the radius in for the lumbar spine because the lumbar spine is not valid. Now, I think we're all familiar with the World Health Organization classification or definition of osteoporosis based on T-scores. Greater than -1 is normal, -1 to -2.5 is called osteopenia. It's also now called low bone mass. You may hear that term. And then less than or equal to -2.5, that's osteoporosis. And then a severe osteoporosis is the same T-score, but the presence of a fracture. The problem with this is more than half of the patients who sustain fragility fractures do not have osteoporosis using this criteria. And also, it doesn't really tell us who needs treatment. Let's go on to the second component of that bone strength I talked about, which is bone quality. And bone quality refers to mineralization defects such as osteomalacia from vitamin D deficiency or renal disease or other metabolic bone conditions, collagen disorders such as OI or Marfan syndrome, nutritional defects, and then high or low bone turnover also has bone quality issues. And then there's something called degraded bone microarchitecture, where if you begin to look at what's going on at the trabeculae level or in the cortical bone, you start to see porosity, thinning of the cortical structures, stress fractures, notching, and all of these are called degraded microarchitecture. And we're beginning to get ways to measure that, and Dr. Dimer will talk about that. One thing to remember that if you think about bone mineral density and what does it do to fracture risk reduction, a small amount of improvement in bone mineral density results in a magnified reduction in bone density of both the hip, but even greater in the spine. And this recent study out of Boston showed that like, for instance, an 8% increase in bone mineral density of the spine, which most medications will achieve, you get a 62% reduction in spine fracture risk, a 38 of hip fracture risk. And so it implies that there's something else going on because this small change in BMD, large gains in fracture reduction, and it really goes to the repairing of these microarchitecture changes that I was talking about that aren't reflected as much in BMD change, but do reflect in bone strength. Now, I did mention bone geometry. This in general is not modifiable. Basic premise is smaller bones break easier, and that's why we see populations who are very short statured, small bone, they have much higher incidence of fractures. And then there's some geometry of the femur, such as a long femoral offset can lead to fractures. And for the spine surgeon, kyphosis increases fracture risk. For every 15-degree increase in kyphosis, there's a 28% increase risk of vertebral fractures. And that does give us something to pause and think about when we're treating patients. So how do we put this together? Well, osteoporosis should be considered as excessive fracture risk. And then there's a lot of things that go into the fracture risk, such as the BMD, risk factors, geometry, falls, microarchitecture, mineralization, and fracture history. The fracture history is one of the easiest things for surgeons to obtain. I think every orthopedic surgeon for sure ought to be able to take a fracture history. But if there's fractures after the age of 50, that is a red flag, even if they've been from car accidents or falls from higher than just ground level. And it's an important determinant of future fracture risk. One fracture, the risk is 2 to 5 times higher in the future. It's also significantly associated with poor orthopedic outcomes. So one thing, ask about fractures. If they've had one after the 50 years of age, that suggests need for further evaluation. This is an interesting database study of a large number of patients who had fractures within 3 years of undergoing a lumbar spine fusion, and then they were followed for 8 years. And they found that the risk of having a vertebral fracture was 40% in those patients who had a fracture within 3 years of their spine fusion compared to 14% if they didn't. But fortunately, there's no different in other fragility fractures. So in other words, prior fracture is a strong predictor and identifies those who need optimization. Now, fracture risk is a much more difficult concept to get our arms around, but there's a new tool, or a tool that's been developed over the last 20 years called FRAX. And most orthopedic surgeons and spine surgeons don't really understand what FRAX is. I'm going to spend a little time going over this. But basically, it's predictive modeling based on 12 risk factors. It can be done with or without a bone density. And the output is a 10-year risk of a hip and major osteoporotic fracture. Just to go over this again, so you have inputs, which are the risk factors and demographic factors. It goes into a black box we call FRAX, and the output are these 10-year probabilities of the hip fracture and major osteoporotic fracture, which includes hip, spine, forearm, and proximal humerus. In the United States, there are medical treatment thresholds that are accepted widely that says if you have a major osteoporotic fracture risk of 20% or a hip fracture of 3%, these are indications for medical treatment. Just as an example, this is one of my patients, 72-year-old female, a little bit overweight, and only had one risk factor. Her mother had a hip fracture. And she had a T-score on her DEXA scan of minus 2.5 of the femoral neck. And in the red box is her output. Major osteoporotic fracture risk at 22%, hip fracture quite high at 10%. So this patient would exceed thresholds and would be somebody who would be referred for pharmacological treatment. Now, you can also do FRAX without BMD. And so you could do this as a substitute when the DEXA is not available. It gives you good insight. It's not as accurate as when FRAX is available, but it is actually pretty good. And it also can be used to screen patients to determine if they should actually have a DEXA scan. The guidelines for this one is a major osteoporotic fracture risk greater than 8.4% on a FRAX without BMD indicates the need for a DEXA scan in the 50 to 65-year-old patients. So this is how this might be used. A lot of people are thinking this would be a good way to screen patients in the clinic. It only takes about a minute and a half to calculate this, perhaps have your MA or somebody put the patient in the room do this. Gives you some insight if they need further management. I think in the future, you're going to see this type of treatment thresholds in a graphical form. When patients are shown this, they much better understand why we're recommending drugs. And I think it's also helpful for surgeons. You know, we're kind of visual. We like looking at pictures, and this also helps us. And so this is available in Great Britain, but not in the United States at this time. And what you have is age plotted on the x-axis and the major osteoporotic fracture risk on the y-axis. And if you put in a patient, for instance, and this is the patient we just talked about, who had about a 25% risk of fracture, she was 72 years old. See, she's in the red, she would be classified as very high risk, and this would be an indication for an anabolic therapy. I think this is going to hopefully come to the United States in the future, and it'll be very helpful for us. So how do you diagnose osteoporosis, given all that I just went over? Well, you base it on three things, and we're going to call this clinical osteoporosis. You base it on fracture history, bone mineral density, and fracture risk. These are measurable, these generalize to many populations, and they provide treatment decisions. Also, a number of the societies, the endocrinology and the bone health people, have come up with risk stratification. And this also is very useful, and the surgeons need to be aware of this. And they're dividing these patients based on fracture risk into low risk, high risk, and very high risk. Now, low risk are the patients who've never had a fragility fracture after the age of 50. And if they've had a T-score, it's normal. And if they've had a FRAX calculated, it's a low risk, less than 3%, less than 20%. And obviously, these patients don't need any treatment for osteoporosis because they don't have osteoporosis. The second group is high risk. And this one is again, the T-score less than minus 2.5, or they've had a history of a remote hip or spine fracture since age 50, or they have that osteopenic T-score where they have a high FRAX probability, again, the thresholds I mentioned, or they've had osteopenia, but they've also had a wrist fracture or a distal femur fracture, another type of fragility fracture, then they would be classified as high risk. And these are accepted indications for medical management. The very high risk patients are ones we do not want to miss because these are super high risk for further fractures. And included in this are patients who have fractures under medical treatment, multiple fractures, fractures when they have on bone harming drugs such as corticosteroids, very low T-scores, less than -3, high risk for injurious falls. In other words, maybe Parkinsonism, or they just fall all the time. Or if they have a excessively high FRAX greater than 30% of an MOF and 4.5. And these patients are indicated for parenteral medications. Most commonly, at least in my practice, I would use an anabolic, although denosumab and zoledronic acid are also recommended. Well, I think all the spine surgeons know the consequences of poor bone health in spine surgery. I've just listed the most common complications that are reported that are really related to poor bone, and the odds ratio of patients who have osteoporosis to don't of having these type of complications range 1.5 to even higher than 7. And so we all understand that osteoporosis can lead to very poor outcomes. So what does a spine surgeon do in the office to screen for osteoporosis? Keep in mind, I'm not advocating getting a DEXA scan on every single patient. What I am advocating is the patient's bone health be assessed to determine if a DEXA is warranted. And you do that by looking at risk factors, perhaps calculating a FRAX score without BMD. Look at height change. If they've had a recent height change greater than 2 centimeters or lifetime greater than 4 centimeters, they're very high risk for osteoporosis. Interpret the DEXA scan yourself. Be a detective. Make sure it's a high quality study. Utilize other tests, and Dr. Dimer is going to talk about these. And then ultimately use that risk stratification to classify patients. And that'll help you decide what is the best pathway for treating the bone health. So in conclusions, T-score diagnosis underestimates risk. Utilize the clinical diagnosis, which is based both on bone mineral density, but also fracture history and fracture risk, and then utilize the risk stratification. So I'm going to end there. We'll have
okay, so I've got about 21 minutes, and I'll try to make this as concise as possible. So I'm going to talk about vitamin D, and the controversy is raging. Steve Cummings just had a big